Okay, so we're going to just wrap up our discussion on childhood for week 9 with some genetic conditions that have childhood onset. Do not be intimidated by the number of conditions we're covering. They should all be relatively familiar, maybe a few new ones, but we have talked about them in this course, and you should have seen a lot of them in 317 in your PEDS course. It is not an exhaustive discussion of these diseases, just how they relate to genetics and how the science of genomics could potentially help people. So our learning outcomes for this unit are to describe inheritance patterns and factors that can influence disease expression in the following conditions: sickle cell disease, cystic fibrosis, muscular dystrophy, hemophilia, von Willebrand disease, achondroplasia, and then we'll just introduce two complex disorders that have polygenic inheritance and environmental factors. We're not going in depth into either of them, just kind of discuss how genes interact with each other and the environment to create a health condition. All right, so the single gene disorders, monogenic. We'll start with sickle cell disease. We have talked in a few different units about sickle cell disease. So the pathophysiology is that you have a protein called beta globin protein, and that influences the shape of a red blood cell so that it can carry oxygen to the tissues. You should know that already. What you might not know is that a change in the bases, a mutation in the gene that codes for this protein, substitutes a valine amino acid for glutamic acid. And that changes the whole shape of the protein. And what we have is hemoglobin S, which makes the sickle celled appearance, where it looks kind of crescent shaped, instead of normal adult hemoglobin, which looks kind of like a donut. Red blood cells with a lot of this hemoglobin S look like this under low oxygen conditions. They kind of fold inward, then they stick together and they get stuck in the blood vessels. They cause a lot of pain and organ damage. And they die faster. So the actual red blood cell count is lower. And this should all be super familiar. In a normal red blood cell pattern, everything flows through blood vessels and transports the oxygen and nutrients to all the cells and tissues. But here with sickle cell, we have these sticky, abnormally shaped cells, and they cause a traffic jam. They can cause swelling in the joints. They can cause inflammation, widespread inflammation, and they cause pain. Okay, so that's what sickle cell disease is. That should be reviewed. Patterns of inheritance should also be familiar because we talked about them when we were doing our Punnett squares. It is autosomal recessive inheritance. It's considered a stable mutation in the population. It doesn't occur spontaneously very often, almost no de novo mutations. We have higher rates in African American and Latino populations, particularly if the ancestors lived around the equator. And I will get into the reason for that. There's sort of an adaptive mechanism with sickle cell trait. You might also remember that. It also affects people of Middle Eastern descent. And one researcher found that there were places in Saudi Arabia where the incidence of sickle cell trait was particularly high and unexpected because there's not a lot of malaria in those regions, which is what sickle cell trait kind of prevents against. But it's thought that intermarriage many decades or many generations ago, along with a population bottleneck where people intermarry a little bit, and consanguinity is more common, led to a higher incidence of this trait being passed on. If you are African American, your risk of being a carrier of sickle cell trait is about 1 in 15. But if you are living in sub-Saharan Africa, the population there has an incidence of carriers that is 45%, very, very high in regions of the world where malaria is common. All right, little more stuff about sickle cell carrier in the context of genomics. We don't identify sickle cell by gene identification. We're not going to look at the gene sequence to find that gene. It is instead diagnosed with a process called hemoglobin electrophoresis, where they look at the shape of the cells that are circulating. Carrier screening might be included in routine prenatal care. particularly if you have a high percentage of African American and Hispanic women. In the event that you identify carriers through prenatal carrier testing, the father of the baby should also be offered testing. Sometimes they decline, but they should be encouraged to have that testing so that you can calculate the probability of a child having that disorder. It's also important for people to know if they have carrier status. As we spoke about early in this semester, people with sickle cell trait under unusually strenuous conditions can sometimes have health problems as a result of just carrying the trait. Sickle cell screening is part of the newborn screen, so babies that are born in the United States who have that screening should be identified early. Carrier screening should always prompt genetic counseling. If you are a carrier of sickle cell trait, somebody should be talking to you about what that means for the probability of having children with the disease. It's pretty devastating. Signs and symptoms: eventually not getting oxygen and nutrients to the target tissues. And also the damage to capillaries is going to cause damage to the organs, scar tissue in the blood vessels, and eventually an early death. Chronic anemia without iron deficiency, because those blood cells with the hemoglobin S die faster. Increased risk for infections, and infections increase the risk for crisis, so you have a vicious cycle. The life expectancy for these individuals is significantly reduced. Carriers of the trait, and this is where it's sort of like an evolutionary advantage to have the sickle cell trait, are usually less susceptible to malaria. And so, that's why the gene persisted. You would think that people with sickle cell trait or disease might limit their childbearing, but if you live longer because you don't get malaria, then you're more likely to pass on your genes. So factors that increase expression of the trait: any kind of crisis trigger, severe cold or extreme hot, dehydration, high altitude. So people living or exercising at high altitudes, infections precipitate crisis a lot of times. Anything that gives you venous stasis, immobility would be a factor. If you have diabetes on top of it and you have some kind of metabolic acidosis or respiratory acidosis, if you have a respiratory event, strenuous exercise, pregnancy is horrible for sickle cell anemia. We've had a few cases of it, and it will precipitate crisis, and then it's difficult and tricky to treat. Anesthesia sometimes will trigger a crisis and trigger more manufacturing of those hemoglobin S and precipitating that abnormal shape, because sometimes the hypoxia will make the gene fold, make that protein fold a little bit more, and increase the sickling. So management, what do we do genetically? Well, stem cell transplantation, it's considered a cure, but it's expensive and not readily available to people because they prefer sibling donors who aren't affected or don't have the trait. And so sometimes it's hard to find donors, and it is expensive, and it can cause severe side effects. Promoting synthesis of fetal hemoglobin through the use of hydroxyurea. So hydroxyurea is a medication that's taken orally every day. And the idea is, okay, they don't manufacture hemoglobin A, which is adult, but we can stimulate production of fetal hemoglobin, which is more conducive to good circulation than hemoglobin S. So hydroxyurea is the leading treatment for that. Reducing oxidative stress with Andari, which is a glutamine. It supplies that amino acid, is thought to protect the tissues in the event of sickle cell crisis. New treatment with gene editing, CRISPR technology. I showed you guys that in a previous video when we talked about CRISPR. Cutting out that defective gene, and then the gene that makes the fetal hemoglobin will take over, and they will have adequate production of red blood cells that are functional and adaptive. monitoring organ function, so looking at labs for kidney failure, looking at hepatic enzymes, um, monitoring lung capacity. Uh, that's an important part of care of a sickle cell patient, avoiding conditions causing hypoxia or hypoxemia. So you're trying to avoid that crisis moment. You create a low stress environment by hydrating the patient, preventing infection, and treating them aggressively and early. If the patient is in crisis, we normally hydrate them with a lot of normal saline, and they get blood transfusions that increases the levels of circulating hemoglobin A. And then supportive care includes pain relief, sometimes patient-controlled analgesia, morphine, Dilaudid. Although patients with sickle cell disease who have frequent crises tend to become very tolerant to opioids, they are an important part of the care for a patient with sickle cell disease. This should be kind of familiar. This is a Punnett square on steroids. There are 6 Punnett squares. If your patients both have hemoglobin A, they make normal hemoglobin, and they don't have the sickle cell trait, your risk for sickle cell disease, having a child with sickle cell disease, is 0. Here's a Punnett square that describes one parent's a carrier, the other parent is homozygous normal. And in this incidence, your probability of having a child with sickle cell disease is 0, but the risk for giving birth to a carrier is 50%. And that's how that works out. You guys should be really used to Punnett squares. This might look a little different from the ones we did together, but this came out of your book. If both parents are carriers, the risk for having a child with sickle cell disease is 25%, because there is 25% chance that they will inherit 2 sickle alleles. Unaffected, also 25%, because in this case, they inherited 2 dominant normal alleles. Risk for being a carrier, 50%. They get 1 of each, 1 from each parent. So that would be how you calculate the probability. If you know both parents' status, whether they're homozygous recessive, homozygous dominant, heterozygous for the trait, that is how you would calculate it through this Punnett square. Okay, cystic fibrosis. We are moving on. I will cover this one because it's familiar. We'll break it off. Then we'll cover the hemophilia von Willebrand, and then we'll go into the polygenic. Oh, we'll do achondroplasia and then polygenic. But cystic fibrosis is a single gene monogenic disorder caused by, there are lots of different mutations that can happen, but they all happen in the same place. They happen in this cystic fibrosis transmembrane conductus regulator gene. That is a mouthful. You don't have to memorize that, but it's the CF, cystic fibrosis, TR gene. A mutation in that gene is going to cause an abnormality in the chloride channel in every cell in the body, which regulates the flow of water in and out of the cell. It has an autosomal recessive pattern of inheritance, similar to sickle cell anemia. And we have used cystic fibrosis to calculate probability for autosomal recessive disorders. The incidence, 1 in 3,000 live births. It is screened for on the newborn screen. Carrier status, somewhere in the realm of 1 in 20 to 1 in 30 Caucasian people. Occurs in other ethnicities far less frequently. But the pathophysiology is that this protein, the CFTR protein, is abnormal and may disrupt that flow of water in and out of the cells. So what you end up with is the formation of thick, sticky mucus. And that happens in the lungs, which gives us an increased likelihood of pneumonia and obstructed airway. It can happen in the pancreas, so that pancreatic enzymes cannot be secreted appropriately, and that person can't digest their food. It can happen in the liver, it can happen in the salivary glands. It happens in the testicles, and when that happens, very frequently the child will be born with an absent vas deferens, because there's no way for that vas deferens to make one continuous tube. So sperm is produced, but it doesn't have any way out of the body. This causes glandular atrophy, reduces organ function. So, the potential disease advantage, similar to sickle cell, cystic fibrosis, carriers have a slight advantage in that they are resistant to the infectious diseases cholera and typhus, which were once very common in Europe. So, there's a possible genetic evolutionary thing there that people who had this mutation in the CTFR gene, but only had one copy, lived longer because they didn't die from cholera or typhus. Now, how do we diagnose cystic fibrosis? Newborn screening right now is formally diagnosed by sweat chloride analysis. If you had a child that had frequent pneumonia or respiratory issues or was failing to thrive because they weren't growing, they would do a sweat test. And from that, they could determine whether there was an abnormality in the function of the cell. Now we can do direct sequencing. There is genetic testing, and that will help establish carrier status or prenatal diagnosis, and it can predict potential disease severity because different mutations have different levels of severity associated with them. Typically, within a family, the disease will follow the same course. Now, cystic fibrosis used to be a really lethal disease. People didn't make it out of childhood. They might make it to adolescence, but they rarely made it to adulthood. If they did, they usually died in their early 20s. But with early identification of cystic fibrosis through that newborn screen, we can offer more aggressive early treatment that prevents the airways from remodeling. It prevents the growth delays that we might see with cystic fibrosis. And people are living longer, healthier lives as a result. So, management, pulmonary physiotherapy, that's your chest PT. You turn the kid upside down and you kind of percuss on the chest or on the back, help them mobilize secretions. Treating infections aggressively and early, preventing infections. So, if this child is vulnerable, we know that people who are sick should not be around this child and should not come to school and infect them. Adequate hydration is necessary, and that thins out mucus. They can do pancreatic enzyme therapy, and that helps the individual get more nutrients, prevents pancreatitis. And then there's other supportive care. They might need a high calorie diet, other medications that help. In extreme cases of CF where there has been damage to the lungs, transplantation could be considered. It does not really attack the core symptoms of the disease, but we're going to take a little break here and come back with Duchenne muscular dystrophy. I'll see you in a little bit.